I'm thinking back to our own road to diagnosis, and it was well into approaching 10 years, fully 10 years since we can look back at those first inklings of symptoms. And they did not get a definitive diagnosis without that PET scan. So with early onset Alzheimer's, I'm really curious how people get a diagnosis. What you can't just do cognitive. I just am curious why we got one only after the PET scan, if it's possible to diagnose Alzheimer's disease without one when you're young.
I understood the question as anybody with Alzheimer's, not specifically young patients. And those are the patients that really do need to see a specialist. I mean, you know, your family had to pay for that PET scan themselves, like from what I understand. So I would leave that up to a neurologist, and we don't have any on the call that I know of right now. So, but the majority, like an 85-year-old with a classic presentation of Alzheimer's, they do not need a PET scan.
Mm-hmm.
You know,
I clarified
40-year-old woman, that's a completely different patient.
Okay.
And Wendy, often with the neuropsych testing, we are able to diagnose Alzheimer's disease, and that's a significant part of my practice, is aiding in determining what are the underlying causes of cognitive dysfunction and figuring out whether or not it is Alzheimer's disease. It's unfortunate that that wasn't the outcome of your cognitive testing, or that it didn't seem like a straightforward response, but that's definitely something that we strive for through cognitive testing.
Mm-hmm.
And I don't understand either when the cognitive testing actually took place, because it made it sound like it was maybe after that accident.
No, how many times? I think there was more than one set of times.
Okay.
And because he didn't go to her doctor's appointments, he didn't have a clear picture of, he only had her version of any story, and it probably wasn't accurate. So once he started going, was well into the different things like, you know, keys and locked in the cars, and the car accident was the catalyst to the PET scan. But before that, there was quite a few signs, like we can look in hindsight, but none of them resulted in any kind of a definitive, I think you might have Alzheimer's disease. And so my comment really is that when someone is exhibiting these kinds of symptoms when they're between 45 and 55, I mean, she was 45 in the very earliest stages. And so when she got her real diagnosis, she was 55. Well, let's call it 5 years before she turned 55. If someone had said, Lisa, do you want to get straight to ruling out early onset Alzheimer's disease, she would have said, yes, I would like to know that. And so I'm suggesting that everybody, when someone is young, she would have had so much more time to rearrange some things that she would have done, and that they would have done, the two of them, with an earlier diagnosis.
Yeah, and I mean, unfortunately, in your situation, you can't go back.
No.
But I hope that she had been working with some kind of specialist or having a referral, because maybe it wasn't on her primary care doctor or therapist's radar. I don't know. But had she saw a neurologist when she was 52 or something, you know, potentially that's when she would have got that test.
Mm-hmm. Except for, like I'm saying, Mel, can you still hear us?
I'm right here.
Okay. I don't know the details of how many times she got a cognitive. Really, these details about Lisa are not as important as the concept that I'm trying to say is, if you know somebody that young, please say to them, let's go for the jugular diagnosis and make sure it's not Alzheimer's, and just not waste very valuable time with more minimal tests.
Thank you so much, Wendy, very much for sharing that. Any other comments from the providers? Anything else you wanted to say, Wendy?
No, I'm good.
You know,
Go ahead.
Go ahead.
Lindsay.
You know, now we have the option also of patients can view their charts or allow access to another family member to view their online record. And that has been such a blessing for individuals that have changes in cognition. So often there might be some defensiveness about letting somebody come along to a visit. But if you're in a doctor's office with somebody, you know, ask about that. Hey, can we get shared access to that chart? Because it is something that can be set up in the office, and that way individuals can keep an eye on the healthcare records, because maybe there was something said to her at an earlier time, but that was before the records were all online and before we could share information in that manner. And so if they're not going to let you join in on that doctor's visit, try to see if there's another way to get at that information.
Great suggestion. Dr. Jurevich, did you want to add something?
Well, I don't want everybody to have the understanding that brain imaging is the only way to diagnose something. It's a combination of cognitive tests, blood tests, history, as well as neuroimaging. So there's a study that I just pulled up here that in terms of PET scans, 34% of young people under the age of 60 have abnormal PET scans. So if you rely upon a PET scan entirely for a diagnosis, a third of the people that are under the age of 60 are going to be called demented. So it's a combination. It's loss of executive function, personality changes, and so forth. And there's no surefire way, quite honestly, to pick up a diagnosis in the early stages of the disease. And I think, Wendy, what you're actually describing is a real testimonial to somebody who perhaps had very adaptive skills. And that's a whole nother question, you know, as to how people adapt to their, you know, disability. And the human brain is amazing. And we have a wide range of abilities to adapt and compensate. And I think your story is an excellent example of a highly compensatory, you know, situation. And, you know, whether it's good or bad, I don't know, but it's you know, it does represent that the way people handle their disease is a little bit differently. Typically, I think the rule of thumb is that the higher the educational level, the more likely they can mask some of the symptoms of the disease. And so again, that's all part of the adaptation.
Thank you, Dr. Jurevich. There is a question in the chat. How early in early onset Alzheimer's will it show up on a scan?
You know, that depends. It varies significantly from person to person. Individuals that have a higher level of education are going to might show changes in their scan, but not show any clinical symptoms. So by the time they go in for a scan, there's more atrophy or shrinkage, or it's more evident on a scan. Whereas individuals with maybe 12 years of education or of other symptoms contributing might show cognitive symptoms early and have no evidence on a scan. And that's also one of the reasons why some of those scans, like there was a mention of paying out of pocket for it, and then Dr. Jurevich mentioned how many individuals will show up with an abnormal scan even in the absence of any cognitive symptoms. That's another reason why insurance isn't covering it yet, is because it's not, in most cases they're not covering it, is because it hasn't been demonstrated as a surefire way to identify or to be diagnostically discrepant. consistently.
There's one more aspect that I want to say. My sister was so young that she did not have enough credits to get work credits to get disability. And so an earlier diagnosis for her would have meant that she was, eligible to get a disability, which would have put her on Medicaid after 2 years. And so there's some of that that's a dynamic for younger Alzheimer's, which makes it more important for the diagnosis to happen earlier rather than later.
Well, and also I think it's not really fair in her part that she didn't qualify for it just because she hadn't worked enough, because disability is for people that are unable to work. So, I mean, those are things that you can write letters to your congressmen and senators. And this is an example of somebody who really needed disability who couldn't get it. I mean, it's pretty straightforward that Alzheimer patient can't have a functioning, high functioning job anymore. But he said she couldn't get it because she hadn't worked enough.
Right. And an earlier diagnosis would have had, she would have had that as the reasoning for her inability to maintain a job. However, those jobs that she got fired from were so long in her past by the time they knew it was Alzheimer's that they didn't start on any disability early enough.
Well, that's one of the reasons why we're doing this this mini conference today is, there are a lot of challenges with diagnosing Alzheimer's disease and dementias. And, hopefully there's the information that was shared today can help providers and people who are impacted by dementia share that information back and forth so that we can get that early detection. So thank you so much, Wendy, for sharing that and asking those questions. I do have some additional questions here that I'd like to pose. One of which is how, and this is for the providers, how does a caregiver express his or her stress to the provider? And how do they talk to the doctor about their stress, and what are ways that you can assist? Who wants to tackle that one?
When I am aware of caregiver burden or stress, that is when, if I haven't yet, I would reach out to the Alzheimer's Association, because we know that they are the ones that can help pick up where we leave off when the individual leaves our office and be engaged in the community, help those individuals connect with available community resources, support groups, things like Memory Cafe or other things that are available throughout the community. I don't know if there's anyone from the Alzheimer's Association that might want to comment on that. You don't need a referral. You can reach out anytime. But we also know that it's more effective if we refer, or if the providers make that connection with the Alzheimer's Association. One thing that I do is I ask, instead of saying, have you been in contact with the Alzheimer's Association? I will say, can I have the Alzheimer's Association reach out to you? And then just get one quick signature from the patient saying that it's okay, and then I submit a recommendation through Epic so that a letter gets sent over to the Alzheimer's Association and somebody reaches out. So I guess I don't have much to say on how to deal with that other than to reach out to the Alzheimer's Association, because they're the experts there.
Yeah, I refer more for the family support than for the patient and the caregiver support. Really, I think they do an excellent job and provide a lot of resources for families and education that they need for the journey that they are going on with their family member.
Dr. Juravich, did you want to add to this?
A little bit. We're trying to transform our clinic operations into dementia-friendly operations. And so some of that means actually putting in a doctor's or a physician order set that gives a direct referral to the Alzheimer's Association. And also, we're trying to do group visits, either through video or live, now that we've getting some new guidance from the CDC about, gathering in small groups. That would be another avenue for bringing caregivers together and giving specific training. There's a program out of HRSA, a federal program that the Alzheimer's Association is working with in conjunction with UND Geriatrics to create some caregiver training. And that in itself reduces caregiver burden, less depression, less hospitalizations of the caregivers, and many other good things that, kind of turn lemons into lemonade.
Thank you very much. Next question, how would you recommend people prepare for their appointments? And how do you suggest family caregivers communicate their questions and concerns with the person experiencing dementia present?
I want to say one more thing about that last question too. I actually have been talking to the hospice, Red River, and palliative care referrals, and working with an organization with them, because there's the early dementia, there's the middle dementia that could be progressive fast for some people, or it could be a long journey, and then there's late dementia. So sometimes people go from being involved with the Alzheimer's Association to going in the nursing home. But don't forget about other support systems like hospice or palliative care, which is really a pre-hospice. But preparing for the appointments, I'm going to take that one first, because with the age of my chart, the kids are like sending you emails all the time about mom's doing this and dad's doing this. I mean, they have access to their chart. They can give me information. So that's one way that they communicate, so they don't like say it in front of mom and dad and embarrass them in the office visit. But I do like that when they come and we try to have open discussions, because sometimes people with dementia get very suspicious, and they have poor judgment, and they think everybody's out to get them and put them in the nursing home. So getting the information ahead of time, and I know that is helpful. Sometimes they'll call too and leave messages with the nurse. I try to get the patient's permission to always have open communication with the family, because we need to all be on the same page. Just like George said, him and his kids were on the same page. We're working to try to keep the patient independent in their home. We're not working against them. So those are just some ideas or thoughts I have.
Thank you, Dr. Anderson. Any other comments? Those are great suggestions. Okay, I think we'll give the providers a little break here. This one is for Mel. What was the first sign, Mel, that you were thinking it was more than something like depression? Mel, if you're speaking, we can't hear you.
I'm sorry. I stepped out for a second. I missed.
Oh,
something.
that's okay. No problem. Do you want me to repeat the question?
Yes, please.
Okay. What was the first sign that you were thinking it was more than something like depression?
Okay. Oh, I'll tell you what it was. And that's when she went in 14, when she was down visiting our daughter in Kansas. And she would pick, our granddaughter would go to school, high school every day. And she stayed there for over a month down there. And she was supposed to go pick up our granddaughter from school every day. And she was always late. And our granddaughter would just get upset. Well, it was something new. And Lisa could not remember how to get back to that school. And she was getting more and more upset with herself, I think. And that's when she told our daughter that she needs to go. She was honestly contemplating suicide. And she told our daughter she wanted to go to the emergency room. And they took her, and then she ended up in that inpatient program for 2 weeks where they did all that. That's where she had her first cognitive tests. And when she was, and I got down there after the 2 weeks to get her, and I read the doctor's report, and that's whenever they said that you need to start getting your affairs in order, basically, that things aren't looking good here. And that was it. So did that answer the question?
Yes, thank you so much for sharing that.
Okay. So that's when I really started, it started getting my attention. And then of course the car accident was not long after that.
Okay. Thank you, Mel.
Yes.
All right, for the providers, maybe Dr. Juravich, maybe I can pose this one to you. Any recommendations for our health systems and how they could improve dementia care?
Well, thank you for that question. Absolutely. We actually have a federal grant at University of North Dakota called the GWEP, or the Geriatric Workforce Enhancement Program. And part of that is to promote and educate healthcare systems on age and dementia-friendly healthcare. And so I see somebody had put in a question about why does not primary care screen for dementia more frequently? And that's exactly one of the positions of the age-friendly program, that hospital systems can get certified to become recognized as age-friendly healthcare. So for instance, Sanford Fargo is the first of the units in the Sanford system to be recognized as an age-friendly healthcare system level 2. So they're at a pretty high level, and doesn't come as a surprise because that's basically where all the geriatricians are in the state of North Dakota and South Dakota for that matter. But there are opportunities for other healthcare systems that we're working with. So for example, we have some of the Indian Health Services, Standing Rock and Turtle Mountain, that are pursuing age-friendly healthcare. And it fits very nicely with their program and their models of care, what are called patient-centered medical homes. So the idea is that you focus on the geriatric 4 M's. And so every time you see a provider, nurse practitioner or a primary care provider, they will ask you 4 questions about what matters to you, your mentation in terms of depression and memory, cognitive screening, your mobility, and then your medication panel. And they'll look for opportunities to decrease medications that may be harmful. They assess you for your fall risk. For example, people 85 and older have a 1 in 3 chance of falling each year. So I think it's a very good question. Is what and quite honestly, the public demand for increasing geriatric principles of care have not been as strong as they might be, and so that's another way for advocacy to promote this age-friendly health systems. And we're trying to have, there's a national rollout, if you will, of a brochure called Better Care for Older Adults. And this will be an opportunity for older adults, when they see their doctor, to engage their provider in those 4 questions and those 4 M's. And hopefully that'll get a little bit more traction for health systems change and improvement.
Thank you so much for that, Dr. Juravich. Dr. Anderson, Dr. Hines, did you have anything that you wanted to contribute?
No.
No, I just was going to add, I mean, we're doing a lot of the mental health screening too, because mood changes, people with dementia do have more depression. So, I mean, that's one thing we are doing at least once a year, screening the mood questions. I have to address this because there's been so many questions in the chat about why aren't we doing this memory test? Why doesn't my doctor do it? You know, if you come in for an annual physical, that's really a wellness visit. So if you're 55 and you want everything done, a memory test is not part of that visit. I mean, it just isn't. I mean, there's so many things that we need to do in primary care. If you want to have a memory visit, I mean, you can set up separate visits, and I know patients don't like to come back for those things. But over 65, there is the annual wellness visit through Medicare, and we do tons of them at our clinic. Patients just have to schedule for them. They come in, the nurses go through lots of screening questions with them. But if you're under 65, I mean, it's just not part of your annual physical exam right now. In fact, it's really not strongly recommended to screen younger patients for dementia. Because luckily these cases are rare, these younger ones. But when there are changes, we want people to come in for those visits, just like if you had a cold or another illness, you would make a special separate visit for that.
Thank you for clarifying that, Dr. Anderson. That's very helpful. So Mel, George, I'd like to bring you back for the last couple of minutes here. When you're communicating the diagnosis with family and friends, what are some tips that you have for others to help them get more support?
Yes, are you talking to me now?
Yes.
Am I on? I guess my feeling on that is when she was first diagnosed, I was recommended to contact the Alzheimer's Association. I had a very good, well, Beth is the one that came to my house probably 3 months after the diagnosis, and I had done a lot of things because had been in the business world at that time. Had done a lot of things that we had talked about, and everyone's different, I guess, is how I'd answer that. Everybody's different and how they're going to react. She read me and she basically told me, she said, a lot of people try and take care of their loved ones. And we tried that. But she said she knew my personality. And she said, all I can tell you, she says, just knowing your personality, she said, if you do that, she said, it's going to take you down. And I really believe that would have happened. I mean, she said, you have to continue living your life, which is as hard as it can be. You do feel guilty because your life changes and you feel like you want to be with them. But there's no guarantees and things happen, and you have to go with the flow and make the best out of a bad situation. And you can feel sorry for yourself. I did for a while until I finally realized that one morning at coffee, I went around it, and every person at my coffee table was dealing with issues. And once you realize that, you just, life goes on. And listen to the people that are telling you, the experts. And I contacted someone that had the same thing that my wife had, the frontal temporal lobe dementia. And I listened to them. One of them said that they made the mistake that when her husband had pneumonia, that they wanted to keep him alive at all costs. I don't believe in that. Once there's the quality of life is not there. And she said it was the biggest mistake I did. They had 2 more years of misery. That may be for some people. For me, I just, I followed the people that I listened to the people that were talking to me. I guess that's all I can say,